Well, hi everyone, I'm Chad Cook. I am part of the Duke Center of Excellence in Manual and Manipulative Therapy. And today we have Dr. Jodi Young, who will be talking about her paper titled Timing of Physical Therapy for Individuals with Patellofemoral Pain and the Influence on Healthcare Use, Costs, and Recurrence Rates, an observational study. This is an open access paper that was published in BMC Health Services Research in 2021. Jodi, welcome.
Thank you. Thank you for having me. Happy to be here.
Can you tell us a little bit about yourself and your current role and your research interest?
Sure. So I graduated with my Doctor of Physical Therapy from the University of North Dakota. And now that I've said that, you're going to hear my accent, even though I haven't lived there for several years. And then I went on to work in outpatient orthopedics, primarily private practice, and then some hospital-based outpatient. And then I got into entry-level teaching. From there, I finished my manual therapy fellowship and then progressed on to my current position, which is the Assistant Director of Research for the Bellin College Doctor of Science in Physical Therapy program. And then just recently finished my PhD in physiotherapy through the University of Newcastle in Australia. So my research background really started in my DPT program when I was teaching. So I worked with Josh Cleland, who most people know, he's a co-author on this paper. And our capstone projects were systematic reviews. And he really encouraged me to take them to publication. He said, if we're going to do them, you might as well try to get them published. So that was kind of my first step into research. And I think my first 6 publications were probably with systematic reviews. And then from there, I did some small clinical case studies, but I really wanted more. And so I really wanted to push towards the PhD, which I then was blessed with the opportunity to work with Dan Roan, who is in the military health system, which is where this data set came from. And this was part of my PhD. And then that led to my current role where now I really help our students with, they also do systematic or scoping reviews, but as well a actual clinical research project. So we're kind of running the gamut with that at this point as to what some of the topics are, but it's been really great because it's helping hone my skills and really let me delve into research even further.
Yeah, there's a couple of good ones there, Josh and Dan working with those. They are prolific researchers. I'd like to talk to you about this particular study. And the research question is, you wanted to assess how use and timing of physical therapy influence downstream healthcare use and costs in individuals seeking care for patellofemoral pain. And that's great because patellofemoral pain, I think, way understudied, especially with this particular topic. And you had a secondary objective where you wanted to look at recurrence rates. Tell me the origin of why you decided to look at that.
Right. So, there is quite a bit of evidence, of course, with timing of PT when we talk about low back pain and spine, but there really isn't as much with lower extremity. So there are some studies on knee, hip OA, but really more in the Medicare population. And patellofemoral pain is such a common clinical condition that we see that it really made sense to look at, what is the timing, what is the effect of timing in this particular population since it's seen so often. There are some things in foot and ankle again, but nothing specific to this condition. And I think it was just something that evolved over time with the PhD to say, hey, let's answer this question because it's out there, but we know nothing about it for this condition.
And you use the military health system data. Can you give us, first of all, why did you decide to use that? And give us pros and cons of using that.
Right. So the thing about it is it's phenomenal as far as the number of subjects that you can get. Of course, in this study, there were 74,408. Even before we whittled down by excluding, we had 121,000 to start with. So that just off the top, it gives you a nice representation of the population itself. Now, clearly it's military health system, and this particular study is active duty only, but it does really, this condition is common in active duty. And so it really gives us a good look at what the landscape would be for this condition. The other thing about this type of data set is it's really nice in that you're very unlikely to get missing data because they have this 90-day validation process. They have a real strict quality control, quality assurance. And so you're able to capture everything in the system. That's the other nice thing. It's a single payer system. So it's very unlikely they're going outside of the system because they don't have a copay in the system. And so you're going to capture everything you want, which is far more difficult in another type of outside health system.
Yeah, I've used the data set myself. I've got a lot of colleagues that are super jealous of the military
Totally.
data system that are big data researchers. So I know in your paper you talk about in detail, you talk about how you narrowed down patellofemoral pain syndrome. Do you mind mentioning to our listeners how you made sure that you were dealing with that diagnosis?
Yeah, so this was something that came up a lot, right? So this was coding. The thing about it is it's reliant on coding. And so when we collected the data, this was time frame is 2009 to 2013. So people were diagnosed between 2010 and 2011, but we got 2 years of follow-up and then 1 year of care prior to the diagnosis. So at that time, it was ICD-9 codes. There were no other codes for patellofemoral pain or all subtypes of patellofemoral pain, no non-traumatic knee pain code. So the 717.7, the condylomatia patellae, that was the most appropriate to use, which, in 2016, there was a consensus statement that came out that talked about these diagnostic labels and how they don't really change prognosis or really treatment. And so although that was later than the time frame that we collected, it still kind of reaffirmed that we had made the right decision to use that code for our analysis.
So you had 74,000 in your study. That's sorry, I'm chuckling when you say that. But you also looked at physical therapy timing and use. Can you define what you mean by that?
Right. So we looked at kind of like our day zero. So people that got diagnosed with patellofemoral pain and then saw a PT on that same day. So they were really the initial provider likely for that individual. And so they were our PT first. And then we had early PT, which was anybody who the day after they got diagnosed, up to 30 days after the diagnosis, that was considered early if they had a PT evaluation during that time frame. And then our delayed was anybody who was seen in PT 31 to 90 days after diagnosis. And we really played around with that time frame because there's so much literature that varies as to what early is. So we did run all of our analyses with even early being considered 7 days after diagnosis or 14 days. But we landed on this because it didn't change our results, and we thought it was a fair assessment for when people would be able to get to PT, still in a timely fashion. 7 days is pretty quick after referral versus 30 is probably more appropriate.
And you had some outcome measures that you looked at too, right? Because you didn't have patient-reported outcome measures, but you had others that may be even more valuable. Do you mind talking about those?
Right. Yeah. So this is the beauty of this data set, right? Where I say it captures everything. So we had everything. So we were able to look at their knee-related care visits. So anything that happened in the 2-year time frame after their diagnosis. We looked at the PT visits. We actually, it was a very small chunk of the paper, but we looked at exercise, those who just got only exercise therapy, those who only got passive modalities as part of their treatment. But then we also were really interested in, as we say, this downstream healthcare use. So things like the pharmacological use. So we had opioids, NSAIDs, muscle relaxers, analgesics, and then we looked at corticosteroid injections. But then the big piece was the imaging. So we looked at the radiograph use, and then kind of did a combination called advanced imaging, which was MRI, CT, and knee arthrogram. So we got that, but then additionally, we got the costs. So we were able to see their overall healthcare costs, so not just related to the knee, but then what was specific to the knee in that 2-year time period as well. So a lot to look at. And then the last thing was that secondary objective where we looked at a recurrence. So if they had a gap of 60 days without treatment for that condition, and then they came back after that 60 days, that was considered a new episode. And so we considered that to be a recurrence.
So before I ask you what you found, because I think you laid that out nicely, what percentage of the 74,000 plus actually received PT?
21%.
Wow, even in the military.
Yes. And And this is a shock to people who read this. You've worked with this data. There's prior papers actually with a HIP FAI data set, similar findings we found. So this for me wasn't the shocking finding of this study, but still very low. We would want to see that quite a bit higher for this condition.
Yeah, that is surprising. I was shocked by that too. So do you mind giving us the lowdown on what you actually found among your categories, if it made a difference with respect to timing for all those outcomes and with respect to recurrence? Please tell us.
Yes, so it absolutely made a difference. So as we incrementally, there were incremental increases for costs, both for knee-related care and for the total healthcare costs, as we moved from PT first to early PT to a delayed PT. The same thing happened for all of the odds ratios that we looked at, which was, determining whether or not they received the PT first or the early or the delayed. What were the odds that they were going to receive imaging or injections, medication use? Again, it was lower for those who got early or PT first, higher odds, increased odds for those who had delayed PT. And then the same thing with the costs. It was this incremental increase that you saw as it bumped up from PT first to early PT to delayed PT.
So, and we have some patients that may be watching this. So in layperson's terms, can you just tell us what this means?
Right, yeah. So when you're looking at odds ratios, basically you're looking at an association or a relationship between what we would deem the exposure and then the outcome. So in our case, our exposure was whether or not they had that PT first, the early PT or delayed PT. And then the outcome is whether or not they received all of these things, right? So the medications, the injections, the different imaging procedures. And so if you have an odds ratio over 1, then yes, you have an increased odds of having that outcome. If it's lower than 1, there's a lower odds, decreased odds. And so everything with our PT first and our early PT groups, they all had lower odds. Everything with our delayed PT, they had increased odds.
And then no PT, there was increased odds too, right?
There actually wasn't. So this is the caveat to the study. So they had the odds of recurrence were lower, the odds were lower, the costs were a bit lower. And so we wanted to make it clear in the discussion that this was a point. And we may talk about this a little bit later too, but not everyone's appropriate for PT. We both sit here, me and you are both physical therapists, we love PT, but we have to be realistic. Not everyone needs it. And in the case of the military health system, what I will say is there are individuals who maybe they can't attend PT. So we don't know if they even got a referral to PT. They may have to be deployed. Or some people just self-manage, right? They just say, no, I don't need this. I'm going to do home exercises. We don't know what goes on with the communication, the type of patient education that goes on. So there is a caveat to that, that if you looked at the results, you might scratch your head and say, well, but look, costs were lower. All these things were lower if they didn't have PT. So you're sitting here screaming about how we need to get early PT, but you're showing me something else. So I just want to express that because I think it's not really an elephant in the room, but it could be if I don't say anything about it, right?
That's a really good point. And you used adjusted and unadjusted odds. In other words, you looked at kind of the health status of the groups to see if it influenced the findings. Can you explain that?
Right. So we felt that was fair because here's the reality. If you do an unadjusted odds ratio, all you're looking at is that association between that exposure when you got PT and then what those different outcomes were. But that's not the reality. The reality is we had a lot of people in this cohort who had comorbidities present. The other thing about this data set, this was active duty again. If you look at our demographic breakdown, we only had 30% that were biological sex female. So we wanted to account for that. So when you do that unadjusted odds ratio, it's just strictly that association between those two variables. If you do the adjusted, you're actually taking into account the fact that there are some other things that might have an impact or influence on that downstream healthcare use. And actually, we know that with musculoskeletal conditions from prior studies that they have seen that there's a difference in healthcare use if you have the presence of certain comorbidities. So we wanted to make sure we accounted for that and we ran both of them.
Did it make a big difference when you adjusted it?
No, in fact, I was just reviewing it again. There's so many numbers in here, but I actually saw many of the categories that when we adjusted, the odds actually got even a little bit lower, which was actually not what I would have expected at all. But
Oh,
that was the case.
interesting. So every study has limitations. I know you reported some in your study. What do you think are the biggest limitations of this one?
Yeah, so I think just the data set in general, it's observational data, right? And that's something that, we run into when we write these papers and you try to submit. Clearly, it's not an RCT. We understand that. I think still information can come from that, but there's no causal relationships, right? So that's why it's all about associations, what the relationships are. But we can't strictly say that, yes, this is what you're going to find. The big thing too, it's all based on coding. So there might be variability in coding where somebody actually coded it as a 717.7, but it wasn't. Or they maybe missed visits and they didn't include those. So we missed some of that coding that happened. I think a big thing is also the results might be different in an outside setting, although I'm not completely confident when I say that, but I think you have to address that as a limitation. The time frame when we collected, again, I'm not confident that we would see that practice patterns have changed, but that's something to make sure to call out. But I do think that one of the bigger things is when we did knee-related healthcare costs and when we looked at recurrences, it was recurrences of knee pain. So what we did is in order to increase the sensitivity to make sure that we got PFP in there, we increased what we allowed. So there were other diagnoses that were able to go in there. And I think we do call this on the paper. And I think of when I first was a PT, I constantly used the 719.46 lower leg joint pain code. So think about that code, right? That probably was somebody who we would think was 717.7, but we didn't use that code. So we wanted to account for that. So what that did is it increased our sensitivity, but it was really the potential existed now where we were pulling in some people who weren't truly PFP. But I will say we did do sensitivity analyses where we did look at these codes differently and the outcomes still didn't change. So we tried to account for that. And then additionally, our exclusion criteria, we took out so many different diagnoses, cruciate ligament, meniscal, fractures, like so many different things. So we tried to hone in as possible, but I think that's probably the biggest one. And then lastly, you mentioned this earlier, there's no patient reported outcome. So we don't truly know how did this influence their pain, function, or disability.
No, I thought you were very liberal in your indication of limitations, although I do really like your study, also an observational researcher, so I'm very biased. So
Right.
I I love talking to researchers just about something that really surprised them. And I know you mentioned a couple things you were surprised about already, but what's the big thing that surprised you about the results of this study?
Okay, so I think this will be something that people don't even pick out. And I feel like this is just how my brain operates. I feel like in fellowship training, when I did things or PhD, like I would see something, people are like, I didn't even think about that. So I am not shocked at the lack of no PT use, but again, I've lived the data set. I mean, you know how this works. You've been in these data sets too. What kind of surprised me is if you looked at the total healthcare costs for those who had no PT, okay, the knee related healthcare costs were the lowest of all the categories. Maybe that makes sense. The total healthcare costs, though, were only about $1,000 lower than anybody who used PT, and they were actually higher than the PT first group. So what I'm curious about, and I kind of came to this conclusion with some of the other studies that I did throughout the PhD as well, is there something going on? For instance, do they have many more comorbidities? Do they have other medical conditions that are preventing them from addressing the knee? And so that's why they didn't get PT and that's why their knee costs were lower. Did they have to focus on these other things? And so the knee got put to the back burner. And so that's something I actually would love to look at the data and say, in this group, how many comorbidities were present compared to the other groups, because we don't know this. Again, we don't know if they self-managed or if they were deployed, but why are those healthcare costs higher in that 2-year time frame?
So that
And
is
I bet
interesting.
you didn't even,
No,
look at that, did you?
didn't even think of that one, not a bit. So again, I think this is a really strong study. What are you most proud of? What's your, you got bragging rights on this one. What would you say?
Well, you said this earlier, like when you work in another health system, you can't capture all of these events. I mean, that's currently where I am right now with the DSC at Bellin College. We work with Bellin Health and they're phenomenal, but we try so hard to do some of these studies and we hit inroads because well, actually they could use this system and get their imaging here and we'll never know, right? So I have to, I mean, major kudos to Dan Roan, because of course I wouldn't have this data set otherwise, and really back up, Suzanne and Josh really helped create that collaboration to begin with. So all of them were so useful. But I think because it's difficult to capture from a whole healthcare system, we're lucky to have that here, but I do think it's representative of what you would probably see in another health system. But what makes me so proud about it is nobody had looked at this, right? So yes, the topic itself is not new. We've seen it with spine. We know that so many people see patients with spine issues, but nobody has looked at this topic. And I know that patellofemoral pain, people kind of go back and forth on it and say, well, it's a hard, is it tendinopathy or is it patellofemoral pain? What should we call it? So it could be perceived a little bit muddy, but I think we did a really nice job of making it clear as we could. And so I'm actually proud to kind of be one of the first people to even look at this in patellofemoral pain. Not one of, I think we are the first people to look at it. Yeah, so that's probably what makes me the most proud about it.
You didn't aim low either. You got 74,000 people. So it's I think the data you have is pretty strong.
Yeah, I think when you open SPSS and you have 632 variables or something like that, and your computer is hot and it's like, please save me, right? I mean, it's a huge data set.
So Jodi, if you were in an elevator and you had less than a minute to talk to a military health representative about the key findings of your study, what would you emphasize?
No, I would really tell them to lean into their direct access capabilities, and because that just showed it right here, right? Like if you had early PT, you were in, or I'm sorry, if you had early PT or that first day, you were much better off. So really take advantage of that. I think, again, be clear about who needs PT, but there's no reason not to try it if the person is capable of attending and that they're able to participate, because again, you have to be mindful of what goes on in a military setting. But I just think maybe there's underutilization of the direct access capabilities and using your PTs as that first initial contact provider.
That's good information. So thanks for sharing your work with us. If someone besides PubMed, if someone wanted to follow you, do you have a social media presence or anything like that?
Well, I don't know if I'd say presence. I am a very much a lurker on Twitter. And if you look on my account, I will retweet things once in a while. I like a lot of things. The thing is, I have to set boundaries because I find so much to read on there from our field that I kind of take those and then I don't let myself get into the conversation so much. But I am there. So it's JL Young 2, the number 2. And so that's where you can find me. Additionally, my email, of course, is on the open access study, so people can reach me there if they want to as well. But I do check Twitter every day. It's just not that active.
Well, maybe you'll get a few followers from this. This was a great paper. Thank you so much for sharing it. I think it's going to be really useful for all of our listeners, and we appreciate you spending time with CNET.
Yeah, thank you so much for having me. Appreciate it.